Let's make a start. Thanks ever so much, everyone, for joining us today. We're really delighted to have Karolin Krause with us today, who's going to be talking about treatment outcomes for youth depression. Are we measuring what matters? And so Karolin is a postdoctoral fellow with the Cundill Centre for Child and Youth Depression at the Centre for Addiction and Mental Health in Toronto, Canada, and is also an honorary research fellow with UCL's Department for Clinical Educational and Health Psychology. And Karolin's research focuses on strengthening the quality, consistency and youth-centeredness of outcome measures for common youth mental health conditions like anxiety and depression in clinical trials and measurement-based care. And she completed her PhD in evidence-based child and adolescent mental health at UCL with Miranda Woolpert and Julian Edbrook Childs. And in her PhD, Karolin used mixed methods to explore outcome perceptions and priorities amongst youth with depression, their caregivers and clinician. And Karolin has been involved in the development of several core outcome sets for youth depression, including as a research fellow with the International Consortium for Health Outcome Measurement. And that was where I had the opportunity to work with Karolin on the ICHOM set for anxiety, depression and OCD, I think it was. And she also has worked as a co-investigator on the Inroads initiative based at the Hospital for Sick Children in Toronto. So huge amount of fantastic work to tell us about. We're really looking forward to hearing it. Thanks ever so much for joining us, Karolin.
Thanks so much, Kathy, for the introduction and for having me. It's so great to be able to tune in from Toronto, where the sun is just rising. So the light in here is still a bit muted, but hopefully we'll get a bit clearer later on. So I thought before I start, I wanted to give you a bit more of background to this question of are we measuring what matters. Before I started my PhD at UCL, I actually spent a few years working in international development, evaluating programs that were funded by the sadly now defunct Department for International Development. And in that role, whenever we started a program evaluation, what we would do first was to create a theory of change together with all stakeholders, the funders, the project staff and beneficiaries, and try and identify the most important outcomes that we should measure as evaluators to get a sense of whether the project is having any impact. And when I started my PhD and started reading different treatment studies specifically for youth depression, it struck me how little evidence there was of such conversations happening with young people and families in the context of designing measurement strategies for treatment studies. And so that became a big interest of mine and still is now that I'm in my postdoc. And that's what I'll be talking about today. So why should we worry about youth-centered outcome measurement at all? I suggest we should worry about it because it is at the core of evidence-based practice, actually. This is a relatively recent definition of evidence-based practice by Woodbury and colleagues, who suggest it is a process for making informed clinical decisions, but it is also a process where research evidence is integrated with clinical experience, patient values, preferences, and circumstances. So we've got the patient or the service users at the center here of that definition of evidence-based practice. And at the same time, a slightly older quote here, clinical trials are only as credible as their measured outcomes. So if they are a prime source of evidence for evidence-based practice, then we should ensure that the outcomes we measure there are person-centered. So both of those things together really lead us towards person-centered outcome measurement, so that we have an evidence base that is built around what matters to young people and their families. And in this presentation today, I'll start off discussing this question, are we measuring what matters to youth, based on 4 sequential studies that I did with Julian Edbrook Childs and Miranda Woolpert at UCL as part of my PhD. That would be the first part. And then in the second part, I'm already giving away some of the conclusion here of the first part. The second part, we'll look at how can we do better, some possible ways forward. And in that part, we'll look briefly at personalized outcome measures, core outcome sets, and also an example of co-producing a study-specific measurement approach. So how person-centered is outcome measurement in depression treatment studies for youth? Are we measuring what matters? When we set out looking at this, we were really interested to know what outcomes youth describe in their own words when they can freely discuss treatment impact. And we were lucky to have access to a relatively large qualitative data set that was collected as part of the impact trial for youth depression. The data, I think, is held between the University of Cambridge now and the Anna Freud Centre in London. And interviews were conducted at several points in time, including post-treatment in either CBT, psychoanalytic psychotherapy, or a brief psychosocial intervention. And we did a qualitative content analysis of 34 semi-structured interviews with youth once they had completed treatment. And in these interviews, youth were asked to reflect on changes that they had noticed over the course of treatment. And we coded and categorized the changes that they discussed into outcome categories. And on the right here, you can see the most prominent ones. These are the outcomes that youth most often discussed when they reflected on changes that they had noticed. And you can see that the most frequently discussed outcome categories here are mood and affect, so a core dimension of depression symptoms, but also improved coping skills, mentioned just as often by close to 2/3 of youth that have been interviewed. And then you can see a third prominent dimension towards the bottom, family functioning. Changes in family functioning were discussed by close to half of youth. And then you can see a few other prominent themes discussed by about 1/3. And this chimes with studies that were conducted earlier, typically with more mixed samples that had a range of presenting problems, not just depression. And these tended to be more qualitative in their approach, so less categorizing, more descriptive of the outcome narratives young people shared, but some similar themes here such as gaining a stronger sense of identity, more parental support, feeling more connected to others, increased self-confidence, to name just a few. And what really struck us with this data was just how strongly coping skills were matching up with the importance of symptoms here from the perspective of young people. And so I just want to briefly zoom in on the coping skills. So within this category, young people discussed a few different things. They talked about learning specific strategies, such as learning breathing or counting exercises, starting to do thought diaries, for example, to keep track of their thoughts and feelings. But they also talked about feeling more in control of their feelings and thoughts and depressive symptoms, being able to handle them, so improved self-efficacy in self-managing their symptoms as well. And just to give you two examples, these are two quotes from youth. The first by, let's call her Madeline, 15 years, who said, "If you're nervous before an exam," she, the therapist, says, "take deep breaths, do the 10 seconds breath exercise that we did, and it actually helps." So this is more looking at anxiety symptoms and depression symptoms, but it does show the kind of practical type of skills that young people were often describing taking away from treatment. And the second quote here from, let's call him Dan, who said, "I think I've gotten a handle on it. So I think that's why I know I'm not going to have much time with the therapist anymore. I don't have to stay on medication no more, because I think I'm able to get a grip on it, I guess." So this is this sense of being able to self-manage. And this theme of self-managing depression and becoming independent from treatment is something that came up actually in a study that was conducted by Holly Bear, who I know is a colleague of yours and was a colleague of mine previously at UCL, where we did our PhDs together. And Holly did a qualitative study looking at young people's illness representations and how they cognitively represent their anxiety and depression. And in her research, Holly found that youth tended to think of their depression as cyclical, waxing and waning, but always more or less present in the background, unlikely to completely disappear. And in that context, she also found that youth discussed the importance of coping and self-management a lot. And this was in a completely different sample from the one that we looked at here. We were then next interested to see, well, what outcomes do young people find most important if they have to prioritize and make a choice, actually? And also, do priorities vary across youth? To look into this question, we did a Q methodological study with 28 youth, so a different sample from the impact interview sample with lived experience of depression. And for this study, we printed 35 outcome statements on individual cards. These statements came from the impact interviews, and they represented some of the outcome categories that we had previously identified. And we then asked young people to sort them individually by importance. As you can see, this was the sorting map that young people were given, and they could only prioritize so many outcomes as the most important, and they also had to place outcomes under least important. So there was a forced choice element there. And we then did something called inverted principal component analysis to reduce the number of individual Q sorts to a smaller set of priority profiles based on similar approaches to prioritizing these outcome cards. And what we found here was, well, we identified 4 different outcome priority profiles amongst this youth sample. The first profile we called relieving distress and experiencing a happier emotional state. And these young people tended to prioritize, what I'm showing you here, just to add, is an ideal typical Q sort that represents each of those 4 profiles and how a typical representative would have ranked their cards. So you can see here that the profile A prioritized 4 different outcomes, all related to the symptom domain, such as feeling more loved, engaging less in self-harm, and feeling happier, enjoying things more. So these young people did believe that their depression might go away entirely, and they were, in fact, quite keen on that. A second profile we called learning to cope with cyclical distressing emotional states. And this really resembles the perspective that Holly found in her research with youth. So you can see that 3 out of the 5 most important outcomes in orange here are coping related. So knowing ways to cope with emotions, gaining a better understanding of feelings and thoughts, being able to challenge negative thoughts, with a bit less emphasis on symptom reduction. A third profile we called understanding and processing distressing emotional states. And this was an interesting group with an overproportionate amount of ADHD, autism spectrum disorder, and learning difficulties. And these young people shared a sense that they had experienced things differently from others for quite a long time, and they had struggled to make sense of those experiences themselves, and had also tended to find it difficult to communicate that to others and to feel understood by others, including their families often. And so outcomes they prioritized were quite different from the ones we saw prioritized in the first 2 profiles. We've got things here such as being able to make sense of things that happened in the past, having a space where someone listens and cares about me, parents understanding me better, and also feeling more optimistic about the future. And finally, the last profile we called reduced interference of ongoing distressing emotional states with daily life. This was the smallest profile, And it included youth who had a number of different co-occurring mental health challenges, including some of them with psychosis, trauma, and so quite severe struggles that they were having. And they felt impairment in their daily lives. They felt they weren't able to do typical things such as take public transport or attend school, etc. And so you can see that this is the only profile to have prioritized a functioning related outcome. It's the number 11 here in yellow. And I know that at last week's seminar, I think you talked about how to treat young people. And so this would probably be a group that's not responding to treatment so easily. And they typically, I think all of these young people had gone already through several cycles of treatment, and impairment is a big topic here. So now we've gotten an idea of a few outcomes that seem to matter to youth with lived experience of depression. Let's take a look at the extent to which these are actually measured and reported in the literature. And when I say the literature, that is quantitative treatment studies for youth depression, which we did a systematic review of. We considered trials and observational studies that were published between 2007 and 2017 across any type of treatment setting, any type of treatment for youth aged 12 to 21. And this is still the old graph that I showed you earlier, with the frequency of outcomes, with the frequency at which these outcomes were discussed in the impact sample. And this is the frequency at which the same outcomes are reported in the treatment studies we reviewed, in the stripe bars. So you can see that there's some match for mood and affect, so the symptom domain, which isn't really that surprising because symptom measurement has historically always been the focus of treatment studies in depression research. You can also see some match between the frequency at which youth discussed suicidality as an outcome and the extent to which it's reported in the literature. But then at the bottom of this graph, you see a really striking discrepancy, where all these other outcomes that mattered to youth were reported in less than 5% of the studies we reviewed, which translates to less than 5 studies out of 92. So that concludes part of our first part of the presentation. So when it doesn't look like we're completely measuring what matters to youth, but maybe we hold that thought for a second, because maybe it's justifiable to measure symptoms as a proxy for overall change, to reduce respondent burden and save time. Maybe that's an adequate thing to do. And we wanted to know whether that is accurate. And this is the 4th consecutive study we did, a bit different in design. So we looked here at routinely collected outcome data from 53 UK child and adolescent mental health services, representing about 500 youth with moderate to severe anxiety or depression. And we were interested in comparing rates of reliable, or let's call it measurable improvement rates across 3 different domains. The symptom domain, this is symptoms of anxiety and depression. The functioning domain. And the third was goal progress. So progress towards reaching self-defined treatment goals as measured by the goals-based outcome measure. And we were interested to see to what extent young people experience improvement across all 3 outcome domains consistently, or whether there is a lot of incidents where they improve in just one domain, for example. And you can see some summary of the results on the right here, and actually only 16% of the sample improved consistently across all 3 domains. And when I say improved, this is reliable improvement, using the reliable improvement index for the 2 standardized, for the standardized measures in the functioning and symptoms domain, and a threshold that is a bit more a meaningful change threshold for the goals-based outcomes. So only 16%. The majority improve in 1 or 2 domains, but not the third. And if we look at this a bit more closely, we see on the left here that 61% of youth who did not improve reliably in the symptoms domain still showed measurable improvement or reported measurable improvement in goal progress. And inversely, of youth who did improve their symptoms, as they reported, over half reported no reliable improvement in functioning. So this would suggest that using symptoms as a proxy for overall change actually gives us a very impartial and inaccurate picture of what's going on, and that there's a lot more happening that we would miss if we took that approach. So that suggests a multidimensional approach to outcome measurement would give us a much better sense of what's happening. So with all of that, how could we do better? What would be some possible ways forward? I'm going to discuss three, I suppose, options or things to consider, starting first with the consideration to complement standardized outcome measures with a personalized measure. For two reasons. First, I've just shown you that there's a lot of change that is captured by a personalized measure, such as the goal-based outcome measure. Actually, I can go back to this. If you look here, 27% of youth improved only their goal progress, neither symptoms nor functioning. And this finding that personalized measures are more sensitive to change is quite robust across a range of different studies for adults and youth. So it seems that we can pick up things that we otherwise don't pick up. And I'll move back here. And so personalized outcome measures have individually defined items. The item content is determined by each young person for themselves, and then they're typically coupled with a standardized progress metric of some sort to check change over time. And these are just on this slide, three options that have received some, well, quite a lot of attention and use, as well as some psychometric analyses. There's the Cyclops kits, for example, John Weiss's youth top problems. The top problems measure has been used in a few trials already. And then probably best known in the UK, Duncan Law's goals-based outcome measure, to just show you three good options. So the third possible way forward to improve the youth-centeredness of measurement is to consider recommendations for measurement that were developed jointly with young people. And a key resource for such recommendations are core outcome sets. Just for those who aren't familiar with what a core outcome set is, it's an agreed, standardized collection of outcomes that should be measured and reported as a minimum for a specific area of health. And typically, core outcome sets have two aims. The first is to harmonize measurement across studies or settings. And the second is typically to ensure that the outcomes measured are meaningful to all key stakeholders. And if you're interested, the COMET database actually is very comprehensive in mapping all the existing core outcome sets. So if ever you're interested in using one, you can have a look by condition or disorder and see if you find a relevant one. And I wanted to discuss two existing outcome sets as examples of how these are created and how youth may contribute to that process. The first is the WellItrom approach. So this is WellItrom is a non-profit who is specialized in developing core outcome sets for use in clinical practice worldwide. And one WellItrom set initiative is the one that Kathy and I were involved in. And all WellItrom sets aim to create a feasible set of recommendations with free measures, short measures that are easy to administer. It's meant to have clinical utility with meaningful outcomes, measures that are valid and reliable and focus on self-report. And they're meant to have global applicability as well. And these sets are typically agreed by an international working group, including clinicians, researchers, and lived experience experts who together form consensus on a set of outcomes to recommend. And for the specific set that Kathy and I were involved in, the WellItrom standard set for child and youth anxiety and depression, as well as OCD and PTSD, there was a working group of 27 experts, 3 of whom were youth with lived experience. And they all together participated in a number of teleconferences and online voting to arrive at the final set. And youth were part of that process all throughout. The final set is very parsimonious, so there was a big emphasis on keeping it as short as possible because it was going to be used in routine care. So you can see that the domains that the group eventually agreed on are only a few. It's functioning symptoms and suicidal thoughts and behavior. And the specific measurement instruments that are recommended by this set were all vetted for face validity by young people. And there are now a few more WellItrom sets for mental health conditions, including psychotic disorders, personality disorders, and addiction. In case you're interested and would like to have a look, they're available for free from WellItrom. And I also wanted to tell you about an initiative that is going on at the Hospital for Sick Children in Toronto, led by Dr. Sunita Monga. This is a team that I work with as a co-investigator, but the people you see on the slide are really leading this. And this is also a core outcome set initiative that's ongoing, but it's focusing on developing recommendations for youth depression clinical trials. And the approach is a bit different from WellItrom's approach in that here we don't have a set working group of, say, 27 that work together over a year. Here we have a core project team that coordinates and designs a number of different research activities involving a range of stakeholders to eventually develop measurement recommendations. And youth are involved at all stages of that process. So just to show you, as for the WellItrom process, the Inroads initiative also started out with a literature review to collect possible outcomes, candidate outcomes that might be important from existing trials. And then at all other stages, marked in blue here, there is some form of youth engagement or youth participation. So at the moment, we're conducting workshops with youth. We're aiming for 7 workshops with 5 to 7 youth each, with different ages from 12 to 24, where we talk to youth for an hour and a half, essentially having them brainstorm what outcomes are important to them. In a third step, youth are then part of an advisory committee that refines a list of outcomes collected through these workshops. The fourth step is an international multi-round survey, a Delphi survey, where participants will vote on what outcomes are most important in a few iterations, and youth will be part of the stakeholders to vote in this survey. The fifth step will be a consensus meeting, hopefully in person, where youth, caregivers, researchers will all come together, look at the results from the Delphi, and make any final decisions together. And finally, youth will also be involved in selecting measurement instruments to capture those domains. And just to let you know that we're in the process of creating an infographic for Inroads, which will illustrate how best to engage young people in core outcome set development. So that would be a nice resource once it's out. And finally, a third consideration for making outcome measurement more youth-centered is to co-design a specific studies measurement approach together with young people as a matter of routine, actually. And I wanted to tell you about another project that's going on at the Cundill Centre, led by Dr. Darren Courtney, where that's already happening. And that's the caribou trial. Caribou stands for Care for Adolescents Who Receive Information About Outcomes. It's a very Canadian project name. And it's a pragmatic trial across 6 mental health services in Ontario. We're testing an integrated care pathway for youth depression, which involves CBT. It can involve medication options and caregiver support, and it does include measurement-based care and shared decision-making. So that's just about the intervention. And in the core team, we have 2 youth partners and 1 youth engagement coordinator who meet with the PI, Darren, every month, and myself, and we discuss the selection of outcome domains, measurement instruments. We look at different options, different scales, and the youth team gets to share their views and gets to select. They have the final say on which measures we include. And we're doing this also in considering WellItrom recommendations. And just to show you, so as part of Caribou 2, we are probably going to use a functioning measure that's recommended by WellItrom on the left here, the Child Anxiety and Depression Life Interference Scale. Our youth team quite liked this measure for its face validity, similar actually to the youth who were part of the WellItrom process. We are also going to use the goal-based outcome measure, recognizing that there's no one-size-fits-all approach to measuring outcomes, that many youth have different priorities and they can be captured by a personalized measure. And finally, the youth team is just now looking at measures for coping skills and trying to find the best option there. So hopefully this will be a measurement strategy that's a bit more informed by youth priorities. So in summary, if you take 3 things away from today's talk, I would suggest you make it these 3. Outcomes like improved coping or family functioning are important to youth, but are rarely measured in depression treatment studies at present. We've also seen that symptom change may be an imperfect proxy for change in other outcome domains, and we risk getting only a partial picture of overall treatment impact if we don't measure multidimensionally. So to do better, there are 3 things we can potentially do, at least. The first is to consider using personalized measures to complement standardized measures. The second is to consider, for example, core outcome set recommendations that were created jointly with youth. And the third is to routinely engage youth in designing measurement strategies for our treatment studies. Just to say that this work I could do thanks to an impact studentship. I'm now supported by the Cundill Centre for Youth Depression and have received personal fees from WellItrom. So a big thanks to all of those for supporting me, and also to my PhD team and colleagues, including Holly, who might be on the call today. And thanks, everyone.
Great. Thanks very much indeed, Karolin. That was such an interesting talk.